So Dr. Ajay Sharma would be talking on FLACS in difficult situations. Dr. Ajay Sharma, please.
Good evening, everyone. I'll be talking on FLACS. This is a technique. When it came, I think most of the surgeons, they discarded it, and even that saying that okay, the patient has to be shifted from one table to another, and it takes a lot more time rather than decreasing the time. But ultimately, it has become a procedure of choice now, and as all those probably who have this machine, like for me, we are doing my most of the surgeries, around 60% are FLACS nowadays. So this is what phaco energy does, and this is what we get in the FLACS: clear corneal incision, LRIs, capsulotomy, and lens fragmentations. The technology gives us 360-degree 10,000 scans here. I'll just skip this and directly go to different. This is how our docking is being done, and then the femto is being done, and there can be LRIs which can be intrastromal or anterior penetrating also, and so we use this in all the cases, whether it can be normal cases where what it does, it reduces the effective phaco time, because lens softening is done by use of by the use of the femto, and effective phaco time is reduced up to 70% in most of the cases. So now we do in different scenarios. If we see the grade 3, grade 4 cataracts, where we feel that while we are working normally with a phaco chop, there will be a lot of edema next morning. But here in with the FLACS, there is negligible edema even in grade 4 cases. We see that on the right hand side, that this is a grade 4, and how nicely there are 4 pieces. The fragmentation has been done, and by just dividing, the already divided thing is, and you can eat on to the lens material, and here, the as I said before, the effective phaco time is less because already the lens is fragmented, and you can see that honeycomb appearance in between. So it is further liquefies the lens, softens the lens, and you can just use less energy, and less phaco time is taken. It can be done in post RK patients. This is a difficult situation. Post RK, we all are worried how it will be done, but normally the central part is always clean in the post RK patients, and this is how the femto looks like. This what we are doing is, this is the femto, and you can see these marks out here. So these are the post RK marks, and yeah, these are the marks, and the femto is being done. And once the femto is done, so you can very nicely take out. You have to give the incision just between the two RK marks, and try to see that the wound doesn't open, the mark doesn't open, which at time does if the cataract is hard and you're taking a lot of time, and if the distance between the two cuts is less. So at that time, then you need to, if that occurs, then you need to suture that wound. This is in the hard cases, the post RK. You can see it's a sort of a grade 4 cataract, and but again we are in between the two marks here and here. This is a toric lens was to be put here, and very nicely you can divide it, and you can eat the nucleus. If we continue with our manual incision and manual thing, so it will take a lot of time also, and chances of the opening of these the scars are more here. So then this is again very important in cases with the hypermature cataracts. We most of the time see that even after doing each and everything, there can be this type of rupture of the capsule. But here in this is an amazing thing. In less than in around 1.2 second, the CCC is there, and most of the cases there is a free floating CCC. Out of, I think, more than 10,000 cases what I have done, there was one case where I found that CCC was not free floating. So this again is a boon, and this is something where we are doing it in a subluxated cataract, and again it is very easy to dock and see. You can see there, this is the gap between this is the gap. You can see the subluxation here. So but here the OCT takes it very nicely, and you can do the capsulorhexis, and once the capsulorhexis and softening is done, then it is again very easy, because again maneuverability here, you can see how much the subluxation is there. But I am taking this rhexis off. Mild hydrodissection is being done, and at a very slow parameters, not very high bottle height and all that, we take the lens out. So this was a patient of thalassemia, and where again the 35 years old only, and there was surprisingly no vitreous loss here because of the age of the patient, and we so nicely keeping just the tip here, and we are taking out the nucleus, and there is no problem, and it was done very nicely. This is something interesting which I would like to show, and I'll close it after that. Is this is post ICL surgery. So we thought there was a patient where ICL was done and the cataract was to be done here. You can see the cataract here posterior subcapsular one. Now it was, the OCT won't take it in one go, so then here you need certain adjustments which can be done. You can adjust the wherever you want it. So like we are adjusting it here, we take these are the adjustment parameters. So you take them up, down, whatever it is, and here we are adjusting the posterior part of the cornea, then the anterior capsule is adjusted, and finally we got it right, and there was the femto was done like this, and you can see very nicely the ICL here. This is placed. This is the ICL above, and this is the lens here. So it can even be done in that. This was one case where we machine didn't take it, we have to adjust. But in second case, this was very nicely taken up by the machine. Look, in first go. So the docking is done, and we can just see this again you can see the ICL here, and in one go it was done. And this was the case where after that we just took the lens out and the ICL out first by undocking it out of the pupillary area, and taking this out, and then the normal cataract surgery was done. Now this is possible with the femto. This is an amazing thing which we found, and so though now once it is done, we can just take out now this is a mild hydro, and we take out the lens also and implant the lens. So we can go on and on, but I think time won't permit it. Thank you very much.
Excellent presentation, sir, and the excellent videos that you have shown, and I think now we can do anything with FLACS in any grade of cataract.